Dr. Ara Duke-Machen. We're broadcasting spine surgery live from the Duke Spine Institute and Surgery Center of Viera. Today our patient comes to us from Louisiana, and he has had an injury to his back several months ago, right? Longer than that. Surgery was 3 months ago. He's had back surgery already, right? So, yeah, he injured his back at work. He's now having horrible back pain. Shot. And he's got 3 herniated discs, L3-4, L4-5, L5-S1. He's in a wheelchair, basically, from the pain. He can't get out of the wheelchair. And nobody in Louisiana is able to fix him or his problem. Give me an AP. So he found out about the Duke laser disc repair and wanted it done. So he's here today to have his surgery done. Now he's got herniations on both sides, left and right. And just lay still and keep quiet right now. And we're starting on the left side. We're going to go bilateral L4-5, bilateral L5-S1 if we can. Unfortunately, he's a big boy. He weighs 300 pounds, a little bit over 300. Shot? Yeah. Well, and because of that, he's maxed out our standard spinal needle, and we're going to have to use a special one because he's really big. Now, this is just keep quiet, all right?
Great.
I'm just talking to the audience, talking to you. Later you can watch. I need to be able to focus here, okay? So we're going to try to get into that bottom disc. Shot. Shot. So I'm aiming for the foramen. I am using our extra long spinal needle. Shot. All right. And let's go AP. It's really important when you have challenging patients like him. He's a level 10 out of 10. He's the hardest you can do. The spine is extremely anterior, very far forward in his body, very hard to get to, and he's big, very big guy. So he's got a lot of soft tissue. So it makes targeting, especially the L5-S1, which is the hardest disc to fix, makes it very, very difficult. All right, we're getting close. You okay? Shot. So I like where our approach is on the lateral view. There it is. Shot. All right, I need to focus.
Where are you feeling that?
Yep, you're going to feel that. Shot. Don't move. I need your help here. Shot. AP. So because of his, where is that? Your back? Yeah, lay still. So the problem is a big guy like this, if we put him too far asleep, then he could stop breathing. So we've got to keep him in just the right place where he's breathing on his own, but he's also comfortable. Lateral. I can't believe it. Just lay still. Let me have some local. All right, so our patients need to be awake in the beginning because basically I need their help to navigate around the nerve roots which are in the foramen. So that's why he's awake. Otherwise, we'd have him asleep. All right, keep quiet or we're going to charge you more. Think that'll keep him quiet? All right, so we've actually made it into the L5-S1 disc, which is, thank God. I'm going to try for the L4-5 on the left side. Just keep quiet and lay still. You're doing great. Everything is going perfect for you. All right? So, once again, for those of you who have never seen this before, we do need our patients awake, helping us. Shot in the beginning. Yeah, look at that. That's not going to make it. Shot. So you see I'm still a long way away from the disc, and yet the needle is maxed out. So I don't think, shot, that's going to make it. The trajectory looks good on the lateral view, but he's so big. His back is so big. That's what makes him so difficult. The back is big. The discs are not hard to fix. His discs are fine. The problem is really just his girth and the position of his spine relative to his lower back, where it's located. Shot? Shot? So I'm letting you watch this part. Some of you may be bothered by it, but I think it's important to see, just even with a very skilled endoscopic surgeon who's done thousands of cases and thousands of discs, that's me, it's hard to be able to do some of these patients, and you have to try sometimes many different trajectories with your needle. You can't just try one and then give up. You have to try different trajectories. You can see the needle is going very steep, which means the spine is very anterior. Let's get an AP. I feel like I'm on his facet joint at L4-5. You could also see the facet joint in front of the needle is a bit arthritic. It's got what we call sclerosis or thickening, and that's from an arthritic process. Yeah, looking good. So we're in good position. You can see the L5-S1 needle is in the disc. All right, any questions from the audience so far?
No current questions, but we do have a few good mornings, one from SARS Logistics and one from Sheriff.
All right,
Sharaf.
very good.
And
Shot?
and we also have a comment from Woody who repeated what you said, keep quiet or I'll charge you more.
Yeah, you like that. It's good to have a surgeon with a sense of humor, right? A lot of people think surgeons are humorless, but even though we do serious work, we can still crack jokes every once in a while. I like to keep it light in the operating room. Some surgeons like the very serious atmosphere. Yeah, so you can see that on that view and the lateral view, that second needle above is maxed out. Look at it, it's abutting his skin here. I can't really go any further. Now if I push the skin in, I can go a little bit further. So let's see, shot. Just lay still, you're doing great. Just
Where are you feeling that?
yeah, this is his bad disc. Shot. So we're in. Yeah, you're doing great, buddy. You're doing great. I'm just wondering if I should change the needle out. What do you think, Luis? I mean,
I worry about
you know,
pushing the needle out.
yeah, it is going to push it out. And I'm already down to the hilt. I'm past the hilt. So just keep quiet. You're doing great. So the reason why patients are a little bit, they talk a bit confused is because they have some sedation on board. So it's kind of like being drunk. You're awake. Of course you're awake, but you're not fully awake. And so if you were fully awake, you keep quiet like I asked you to do. All right? All right, so we've got 2 down. We got 1 more to go on the left side. That's the L3-4. So this patient is in so much pain in his back that he literally cannot walk. He's in a wheelchair. Even though he's got good strength in his legs, this just shows you how painful a disc injury can actually be. Disc injuries can be extremely painful and debilitating. Now he and I have a great relationship. He's actually a boat captain, and he's just not able to stand and do his job. So he wants to get his back fixed so he can get back to having a normal life. He's here with his lovely wife, Shot, and I'm sure she's just as anxious for him to get better as he is. That's something that we encounter a lot, Shot, is that a lot of family members suffer along with the patient because they feel for the patient. They want their family member to be out of pain. Just lay still, you're doing great. You're doing great, just lay still. You're almost done. So we're just about done with this. Hey Luis, help me out here. Hold these over.
Yes, sir.
Just over there gently, so I can try to get this last one in position. You're fine, lay still. Shot? Yeah. He's definitely a level 10 out of 10. Shot? Yeah. Where do you feel it? All right, Shot, AP. So we're just outside the neural foramen in the bottom half at L3-4, exactly where we want to be. But I'd like to get an AP view just to see where we are on the anterior posterior view. You want to be not too far from the disc. Hey, that's perfect actually. You're doing great, my friend. We're going to fix your back. Of course you're hurting. You're having surgery. What do you expect?
Yeah, you're doing great. Just keep your head down and don't move your head. You're doing well. Perfect. You're doing well.
So, Shot, this guy is a big guy, but very low pain threshold. Shot. Of course it hurts. So he's hurting even though we just have a needle. That's it. So some people have a much higher threshold. Other people have a lower threshold for pain. Shot? You're doing great. You're doing great. Shot? Yeah, just need a little bit more up. Rostral. You're fine. Hold on, let me see. So I'm hitting the end plate there, and I want to aim a little bit higher. Shot. That's better. All right. Yeah. No, it's his number one, his pain threshold is like on a scale of 1 to 10, 10 being a Viking, he's like a 0.5. Okay? Definitely not Norwegian blood in here. All right.
I'm just making sure it's not traveling.
I'm kidding. The reality is these pain signals go from back here to the brain, and they go to this area called the primary somatosensory cortex. I'm going to give you some more numbing medicine. Just going to feel a little stick and burn, okay? Don't get upset. Don't move. And we're all basically born with connections of neurons to what are called receptive fields, and it's pretty well established that obviously pain is an electrical signal that travels up the nerves to the part of the brain that interprets those signals, which is the primary somatosensory cortex. So people with low pain threshold probably have their wiring is just different. And yeah, I guess we should start with the big one, right? No point in starting with the small one, because we know it's not going to work. So basically, people with low pain threshold, I believe it has to do with their wiring of their brain. And just how many nerve fibers, for example, end up innervating a certain area of your body. We see people with back pain from the discs that's debilitating, that some of the people have some of the people have very low pain thresholds and some of them have very high pain thresholds. I don't think that that's a factor because they all come here for the same reason. They have discogenic back pain and they want to get rid of it. So in other words, they have pain coming from their disc. You okay? He's a little more comfortable now. Shot? All right, so I'm a little bit too medial and a little too superior. Oof, there's like no space here. Shot? Shot? So I'm having to do a lot of navigating of the needle. You see how I'm using pressure to deform the needle and bend it and try to get it to where I want it to go? We call that the jockeying. All right, shot. Let's get an AP and see where we are. I'm up against the facet, I believe, on the right side at L5-S1. If I can get the right side, great. I really want to, if possible. There it is. So you see the needle on the right side. It's up against the facet joint. Jordan, show them that on the x-ray. Stay on the x-ray, Henry. I'm going to have Jordan point it out with the white arrow. Now you can see the facet is enlarged. Show them the enlargement. And when facet joints enlarge, that's not it. It's right there. See where the tip of the arrow is? Right where the needle is. That's enlarged facet, and it's enlarging laterally to the side, which blocks my access for the needle to get into the foramen. So if it wasn't hard enough as it is because of his size and the position of his spine, now it's even harder lateral because the needle is being pushed to the side, away from where my target is. So I can't fix arthritis of the facets, and if I can't get around the facet joint, we can't do this side. So I'm going to try a little bit more, but I could feel, shot, I could feel his bone there, and it's just blocking me. And this is why most doctors don't do L5-S1. There are not a lot of endoscopic spine surgeons in the world, but the few of us that there are, they just don't treat L5-S1 transforaminal. They do it translaminar, which means opening up the lamina of the spine. Shot? Which we don't want to do, by the way, because that destroys the spine. All right, I'm going to try a little bit more upper rostral cranial approach and see if I can get that disc. Shot. So you can see I'm starting more north towards the head and seeing if I can get it because the iliac crest is starting to block me as well, inferiorly. Shot. Shot. He's snoozing now. All right, I feel the bone. Oh, I might have gotten around it. Shot. All right, let's get an AP, just see where we are. So again, on a scale of 1 to 10, this is a level 10. 99.9% of endoscopic spine surgeons in the world would not be able to do this surgery. And the reason is, as I've stated, anatomical constraints is what we call it in the business. The anatomy of the patient is constraining my ability or preventing my ability to fix this stuff. But I'm not giving up. Not yet. Shot? All right, so still bumping up against the facet. There we go. Shot? I'm coming around it. Shot? Let's get another AP. That's fine. So we're using our x-ray to guide the surgery. All right, so we're pretty darn close on that view. You can see how tight it is. Not a lot of room. Really close to the lateral margin of the disc at this point on the AP view. All right. How reliable is he? Shot?
How you doing? Well, okay, we're just going to ask you a question. Do you have any pain down your leg? Any pain down your leg, my friend?
Shot? Are you having any pain? All right. I'm just going to wait until he's a little more reliable, but I'm going to get my next needle in position as well. So I need to make an incision. Our incisions for the surgery are 7 millimeters. They're very small. That's a 1/4 inch. Very small incision. A little bit bigger than a 1/4 inch, but not much. All right, now I'm going to aim for the L4-5. You're fine. Lay still.
Lay still. Keep your head still.
Shot.
Keep your head still. We're starting it now. Keep your head
No, you're fine. Everything's going fine. Just lay still. I need your help here. Sure. Yeah. Let's have some num-num. We're going to give our patient a little bit more numbing medicine under the skin here. See if that helps. Shot.
Stay still. Stay still.
Shot. All right. Henry, while we're doing this, let's go ahead and run our video showing how does a herniated disc actually cause back pain. Shot.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. Where do you feel that? Back? Huh? All right. There's an old saying, better to be lucky than good, huh? I seem to be saying it a lot lately. But, yeah. Yeah. So, very fortunate. He's got, hey, lay still. Keep quiet for a moment. You're going to want to hear this later. He's got 3 discs that are damaged. I'm going to draw them for you. You all see this here?
Yes, we do.
This is the L5-S1. This is the L4-5. And the L3-4. You're doing fine. Everything's good. He's got tears. My wife watched this the other day and said, "You're drawing fingers on people's backs." I said, "I'm not drawing a finger. I'm just drawing a disc."
Okay, stay still. Stay still.
No, you lay still.
Stay still. You're gonna stay still.
You get up, we're not going to do your surgery. You're going to be in a wheelchair the rest of your life. Is that what you want?
Stay still. Don't move. You're not getting up.
All right. Lay still. Control yourself. All right. All right. I'm sorry. You're going to be okay. We're going to put you to sleep in just a minute. Of course you're not going to do this again. How bad is that on a scale of 1 to 10? 10. Is that where you get your pain? 10 over 10. Concordant. All right, all right. Relax. You're doing great. Everything's okay. No, you're not getting out. You just stay still, all right? Everything's fine. So, unfortunately, what we're hearing... How bad is that on a scale of 1 to 10? Is that where you get your back pain? Is that where you get your back pain? Is that where you typically get your back pain? Yes. All right. Sorry about that. We're going to put you to sleep in just a moment. You're almost done. You're doing great. You're doing great. You've come so far, okay? All right. All right. How bad is that on a scale of 1 to 10? Is that where you get your back pain? All right, you get to go to sleep now. When you wake up, we'll be done and that pain will be gone, my friend. It'll be worth it, I promise. All right, so I guess we could take a moment and talk about pain versus affect. So pain is obviously an electrical impulse, goes to your brain, you feel pain. Affect is sort of how you respond to it. And a lot of people get depressed. A lot of people get anxiety. A lot of people get depression and anxiety. So pain has a different effect on different people depending on their psychological makeup. I say we start with L3-4. Get that out of the way. And then L4-5, get that out of the way.
Do you want to put a needle or leave that guy right over here?
I just leave it alone.
Leave it like that? Okay.
Right?
Yeah, we can.
Let's just do L3-4. And then we'll mess with the other stuff. All right. You're doing great. Take your time, Dr. Bernes. Be safe. I'm excited for this guy. This pain is going to be gone. All right. So far, Henry, we've shown what causes back pain. How does a herniated disc cause back pain? And then the Duke laser disc repair, right?
We have not shown that, no.
What have we not shown?
We have not shown the how the Duke laser disc repair
I
works.
asked you to run that video. Go ahead and run that video now. Okay?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. You've seen now how the Duke laser disc repair cleans out the tear in the back of the disc called the annular tear, posterior annular tear, to, it's called the debridement, and we eliminate pain by getting rid of that herniation in there that's stuck inside the tear. Everyone thinks it's the herniation coming out, but it's not. It's the herniation stuck in the tear that causes back pain. Shot? At this point, he's sleeping beautifully. He's not doing anything. I'm fine with him, Dr. Berners. If you want to lighten him, he's fine. We're now driving the endoscopic tubular retractor into the L3-4 disc. Jordan, you want to show the audience the L3-4 disc and where the tube is? All right, there's the L3-4 disc. That's the top one we're fixing today. You can see the tube right there, the opening. So where's the tip of the tube? Exactly, all right? So we're in actually very good position at this point. I'm going to remove the dilator and keep the tube in place, and then we're going to get started with the laser. Let's see, shot? All right, so.
Can you grab it like that?
Uh-huh. That's a great idea, Luis. Damn you, good. So I've got my man Luis here helping me. Smart. There we go. So dilator's out. You guys see this, Henry?
Yes, we do.
And take a look at the x-ray. You can see the tube is in position in the back of the disc. Now notice, Jordan, Henry, let's stay on the x-ray. Jordan, you want to show the audience the annular tear. You could show them the dye inside the L3-4. And if you rewind a little bit, you go back, you see the tear was right there. And that's where our tube is. Our tube is inside the tear. We're not doing any damage to his disc whatsoever. We're just going through the part that's already damaged. A lot of people ask me that question. Dr. Duke, what happens when you go into that annulus? Aren't you damaging it? No, we're going through the part that's already damaged. So we're not creating any new damage. Every other spine surgery out there creates new damage, but not the Duke laser disc repair. It's the only surgery in the world that does not create new damage. The only thing we're doing is cutting your skin. And you saw how tiny that cut was. Now I had a Jehovah's Witness asking me questions on YouTube. They were asking me, how much blood loss do you have, and do you have to do a transfusion? And I said, we've never had to do a transfusion. In all the years I've been doing this surgery, 16 years, we've never had to do any blood transfusions because there's no bleeding. The chance of needing a blood transfusion is higher with cutting your nails than Duke laser disc repair. Typically, we'll lose a few drops of blood. That's it. There's something going on with the scope, maybe? No? Boy. We are now inside the herniated disc at L3-4 on the left side. And all this is part of the herniation right here. I'm going to use this laser to zap it away. To give you an idea of the size that we're dealing with in here, that fiber, the glass fiber you're looking at, the laser fiber, is actually 1 millimeter. 1 millimeter, okay? So that should give you an idea of basically how thick it is, right? Okay, there's the herniation. That's part of it. Now this is the part right here that's been pushing on his nerve, causing his leg pain. So let's see who's been paying attention in my audience. Pressure on the nerve root. What does that cause? Pressure on the nerve root from a herniated disc. Let's go through some possibilities. Does pressure on the nerve root from a herniated disc cause back pain? No, absolutely not. Never. Not one single time does it ever cause back pain. Not a single human being. That's the biggest myth or misconception that I hear from people all the time. Even surgeons, they think a herniated disc or pressure on a nerve root causes back pain, but it doesn't. okay? There's plenty of examples. Not just herniations, but also tumors, fractures, okay? Pressure on the nerve root does not cause back pain. Does pressure on the nerve root cause sciatica or pain shooting down your leg? Actually, the answer is no. Pressure on the nerve root doesn't cause pain shooting down your leg. What does pressure on the nerve root cause? Causes weakness in your muscles that the nerve goes to, okay? If it's your L5 nerve root, it's going to cause weakness of your tibialis anterior and your extensor hallucis longus, usually. So that's the muscles that cock your foot up, okay? That's why people with a herniated disc and a pinched nerve, L5 nerve root, they have trouble walking because their foot's dragging. Anyway, you see how thick this white stuff is? This is all scar tissue from inflammation, from his herniation. It's herniation and scar tissue. This is what was crushing his nerve, causing weakness in his legs. This was not causing pain. What else does pressure on the nerve root cause besides weakness? Numbness. You're doing great. Hang in there, buddy. Pressure on the nerve root also causes numbness. So people get numbness in their foot, in their leg. And finally, the last thing pressure on the nerve root does, it causes tingling. Like we call them paresthesias, but it's kind of like your foot or leg is falling asleep. Okay? So the pressure from a herniated disc that all these surgeons are talking about fixing with microdiscectomy, laminectomy, that pressure and that surgery, microdiscectomy, laminectomy, it only fixes, if it works, which is a big question mark usually, it only fixes weakness, numbness, and tingling. So what fixes pain? Well, the pain comes from inflammation. And where is the inflammation? It's coming from this right here, the tear. That's why the Duke laser disc repair gets rid of back pain and leg pain, because we're treating the source of the inflammation, which is the tear. All right, I understand we have some questions from our audience, so I'll take those now.
Yes, the first question comes from Woody on YouTube.
Hi there, thanks for asking.
And they asked, I'm watching as I'm interested in the surgery. I am age 49 from the UK with L5-S1 and L4-L5 herniation 10 years ago. Now diagnosed with degenerative disc disease, I have 2 MRI scans from NHS. Is there a guide towards costs?
There is. Okay, so first of all, thanks for watching. And nice to hear some of our friends are overseas are engaged in the YouTube and the live surgery. We have a lot of people from England come here to Florida for this surgery, okay? And they're very happy with the results. The cost of the surgery depends on how many discs we're fixing. So you're telling me L4-5, L5-S1. So let's assume that you are correct. It's your L4-5 and L5-S1 that is the source of your pain. Then to fix 2 discs, it depends on if we're going on the right side, left side, or both sides. And the best thing to do is to use the link we're about to type. That is the mri.dukespine.com, right? It's a free MRI review. We don't charge you for it. It's free. And using that review, we can tell you exactly what needs to be done to help you. That's how this patient found us, and this patient is now here getting surgery. So he found us on the internet. He used the free MRI review. We did a Zoom call, which I'm sure you're familiar with Zoom. Most people are at this point, even I am, and I'm a tech dinosaur. So we used the Zoom call. We did a nice meeting for 10 minutes. I looked at the MRI. I saw that this patient had 3 herniated discs. And by the way, most doctors tell patients they only need 1 or 2 of those discs fixed, but sometimes there's 3. And so I don't want to miss anything with you. That's why the MRI review is important. It doesn't cost you anything. It's free. All you got to do is fill out a form, type in your information, phone number, name, etc., where you're having your problem, and then submit your MRI images. Your MRI images can be found on a CD if they gave one to you. They're called DICOM, D-I-C-O-M images, and you can literally open your CD on your computer and sweep them in to our portal on the website and upload the images that way. That's what this patient did, and here he is getting his back fixed today. Lay still, you're doing great. Everything's fine. We're just fixing your disc. All right. Beautiful. Yeah, you're doing great. So you can see there's a lot of herniation here. All right, I know there's a bunch of questions, so I'll take the next one.
Alrighty.
You're doing great, buddy. Just hang in there.
This next question comes from Estelle on YouTube.
Estelle. All right. We've heard from Estelle before.
Yes, we have. And they asked, "Hi, Dr. Duke. My question is how do you approach for central disc herniation, transforaminal slash interlaminar? If it is transforaminal, please tell me how, because it's very difficult to reach central area by TF."
Yes, Estelle, you're first of all, what Estelle is asking about is when the herniation is not off to the side but more central, how do you address it? And do you go through the foramen like you're doing now, or do you go through the lamina? The answer is I always go transforaminal. And the way you address it is you go more lateral with your entry point. You need me to stop or what? So just lay still, you're doing great. So Estelle, rather than starting just off the midline and going towards the spine, if you have a central herniation, you want to start as lateral as you can. And obviously as lateral as you can means you have to know the patient's anatomy, right? Because you're going to be potentially violating the peritoneum and getting into their abdominal cavity, and you don't want to do that. So you have to have a lot of experience and knowledge about the proper approach. But long story short, you're asking how I do it. I always go transforaminal, even for central paracentral herniations, because number one, the symptoms always come from the side, more lateral, even though the majority of the herniation is central. And central stenosis rarely causes radicular symptoms. But if you have a large central, you can go bilateral, transforaminal, just have a more lateral approach or lateral entry point, and try to angle more medial with your approach. And that should be able to get enough of the herniation. And you know, my advice to you is don't focus on imaging results, focus on patient satisfaction. And you know, the days of using MRIs and x-rays to justify our work and say how great we are over. Obviously, if you're going to put hardware in and reconstruct somebody's spine, you're going to want to make sure the hardware is intact, the alignment's good. You're going to want to look at the curvature, make sure you have a good curve. You're going to want to look at the hardware, make sure that it's not loose and that it's in proper position. But aside from that, I don't use diagnostic imaging post-operatively to determine if I was successful, because what I use is the patient. The patient will tell me my pain's gone, and my back pain's gone, my leg pain's gone. And then I'll do a physical exam. I'll check their strength in their leg. And if they had a weakness before surgery, I want to see how much improvement they have. And generally, with this surgery, you're going to see improvement. You're going to see the nerve roots return to normal function. It may not be immediately. It may take time. It could be delayed because some people's radiculopathy is so bad that it takes time for the nerves to heal, right? We all know that. And I know that because I've done so many open decompressions, and I've seen so many patients over the years, 26 years that I've completely decompressed the nerve root. And I know for fact that I did a very good decompression, open decompression. And that some of the people just require time for that nerve root to heal because it was damaged so badly before the surgery. Okay? So hopefully that answers your question, Estelle. All right, next question. And I apologize for the haziness today. That's just bleeding, and it's coming from the end plate, which is the bone. Okay? And I'm trying to minimize it, but in the end I can't stop. And that's tiny bit of bleeding, by the way, for those of you wondering. It's not anything more than maybe a drop every 5 seconds. It's just that we're so magnified with the view, you're seeing everything. Great question, Estelle. Who's next?
Our next one comes from Sharaf on Facebook. And they said, I sent MRI pictures and report as you asked. The MRI review asking for new MRI. My MRI was done on December 20th of 21. My lower back, my doctor ordered for an L4-L5 bilateral lumbar decompression.
Okay. Was there a question?
I'm so sorry. I don't believe there was a question. I think it was just
yeah. So
what they wanted to share.
Whoever is asking that, I want you to understand an L4-5 decompression surgery is a laminectomy surgery, okay? That's what they're going to do. And laminectomies never fix back pain. They only help leg weakness, numbness, tingling, okay? The problem, though, is that the compression that's happening is really mostly likely coming from the disc herniation. And the disc herniation's in the front of your neuroforamen. It's in front of the nerve root, okay? So what's happening then is that we're done here, is that your surgeon is going to unroof the spine from the back, but that's not fixing the source of the stenosis, which is the herniated disc. You're doing great, buddy. Just hang in there. So I would not recommend a decompression because it's not addressing the source of your stenosis or the source of your back pain, which is the herniated disc. What you need is the herniated disc removed to get rid of the stenosis, which he may do a microdiscectomy, and that will relieve your leg symptoms of weakness, numbness, tingling. But until you clean out the actual tear, which is what we're doing with the Duke laser disc repair, if you don't clean out the tear where the herniation came out of, then you're just going to re-herniate and you're going to continue to have back pain. So I would not recommend the decompression unless you only have leg weakness, numbness, tingling. If that's your only symptom, then consider it, but it's still a bad surgery because they're going to remove all the bones and ligaments out of your spine to do your decompression. Luis, I need you to hold these so they don't come out.
Yes, sir.
Okay, so we're done with L3-4. Now we're going to move on to the next one, which is going to be the L4-5. Come on in, Jordan, with the x-ray. So this is going to be a longer surgery because we're fixing 5 areas, 5 spots on 3 discs. Left L3-4, both sides at L4-5, both sides at L5-S1. Henry, it's a good time for questions.
Yes, we have a question from Lydia Sellers on Facebook.
Thank you.
And they ask, hello, how would you repair a reputed disc that curves and presses on a single cord? Affects three of the vertebrae, all on the left side. Severe back pain yesterday, ended up in the ER, which they did nothing. Pain meds, steroids, that's it. No new MRI in several years. I know I need a new one.
Yep. All right. So first of all, thanks for being here for our live stream. To answer your question properly, you need a review of the MRI, the new one, and I need to do a Zoom call with you. This is it right here, right? 4-5, yeah. So what I would recommend is get a new MRI from your doctor of the area that's bothering you. It sounds like lumbar. Shot? Lumbar, right? So lumbar is your lower back. The other thing to know is that there is no spinal cord in the lumbar spine. So I'm not sure if your herniated discs are lumbar, but if they are, they're definitely not pushing on your spinal cord unless they're the top of the lumbar spine, huh? Go ahead. So the spinal cord is only in the cervical spine, which is your neck, and your thoracic spine. Yep. But the fact that your MRI is old is a bad thing. We need something new within a year. And Henry is going to put the link you can use. It's the free MRI review link. We offer a free evaluation, look at your MRI, examine you, talk to you, get some history, do a physical exam. All of that is important to make the right diagnosis. There's no way to make the right diagnosis about what's wrong and how to fix it without actually having the actual MRI to look at the images, as well as having a physical exam. The physical exam allows me to examine where your pain is exactly on your body topographically, and to make a determination about the source of the pain and symptoms. So an MRI by itself doesn't tell a doctor where the patient's symptoms are coming from, because they can be very misleading. And so we don't use just MRI by itself, ever, because you'll make the wrong diagnosis most of the time. Okay, take this.
Yep. She commented and she said it was her L3-4 through 5.
Yeah, so L3-4-5, there's no spinal cord. There's just nerve roots. Shot? Yeah. So it's probably your nerves that are getting pinched or irritated, and that's something that we can help you with, okay? You want me to inject a little more into the disc? Huh? Shot?
We have a few more questions.
Sure.
This next one comes from...
That should be good.
This next one comes from Woody, once more on YouTube.
From who?
Woody.
Wait. Shot? Uh-huh. Oh, it's good.
And Woody's asked, I've requested my 2 MRIs under Freedom of Information Act, NHS, and will send over. Will there be a video of this gentleman before and after? It would be very exciting to see.
Yeah, Woody, great idea. You know, we didn't do a video before, but he would have been a good one. You're right, because he's in a wheelchair. So I can't provide a video before. And videos after are really up to the patients, whether they want to or not. We ask patients sometimes. Some of them don't want to because they may have their personal reason, whatever it is, for not doing it. But hopefully he'll be doing well and we'll be agreed to doing a video. We'll see. So we just never know. You know, it's very kind of patients to be willing to do the video, but it's not expected, obviously. We're here to fix them, and we respect their privacy, but fortunately a lot of people are willing to do a video testimonial afterwards. So some people just choose not to. I know for him, he's got a work comp case. So he's injured at work. His work comp insurance agreed to have this surgery done. It's a lot safer and less expensive for them and a faster return to work. So they love the surgery over fusion, which would be his alternative. A fusion surgery is far more invasive, as you can imagine, and more bloody, more pain, and when most doctors do fusions, the complication rate is much higher. It's very high. It's around 25 to 50%. Somebody like him who's morbidly obese, huge person, you know, that complication rate could be as high as 50%. Whereas with Duke laser disc repair, we've not had any complications, any surgical complications. Okay, so it's a much safer surgery. So the insurance companies like it because it's cheaper for them. Patients get back to work right away. There's a herniation right there. You see that thing just pop out? That's a piece of herniation. There's lots of them, by the way. He doesn't just have one. And that's something we've talked about before, is that herniations are typically 20 or 30 pieces. So that means there's 20 to 30 episodes of herniation that happen. Okay? Everyone thinks a herniation happens once and that's it, but it's not. Herniations keep happening as long as the tear is there. That's why one of our goals is to let the tear heal, but it will not heal on its own. It must have the Duke laser disc repair. There is no other surgery in the world that allows the tear to heal except for the Duke laser disc repair.
We have another question.
Uh-huh.
This comes from S. Dell once more on YouTube.
Sure.
And they asked, Dr. Duke, I like your confidence and thank you for your kind details.
Thank you, Estelle.
My next question is, will you do a little bit of foraminotomy to enter disc because sometimes it sometimes can be difficult to get access to?
It's a great question, Estelle. Yes, a foraminotomy can be done. However, if you understand my technique, which I think you do, I do the inside-out technique. So I don't start outside the foramen and do foraminotomy, okay? Though a lot of doctors like to do that. I have found it unnecessary to remove the anterior facet to get symptom relief in patients. But you're talking about drilling away, removing part of the facet in order to gain access to the disc. I think that's fine, but you're going to get bleeding, and then you're going to have, you know, maybe the surgical field gets obscured, and then you have to deal with that. It's probably okay. It's hard to control bone bleeding endoscopically, as you know, but it's not impossible. So the answer for me is no, I don't ever find that necessary. But I have aborted maybe, you know, I do abort rarely, but once in a while I'll have to abort a case because I can't get around the facet. And that may actually be a potential solution for that. So it's a good thought. Did I answer the question there, Henry?
I believe so, yes. And we have another question from Lydia, once more on Facebook.
Oh, yeah, and by the way, Estelle, my confidence comes from success. Basically, successfully curing people's pain over the years, thousands of people. And so I'm confident in the treatment. And, you know, I'm a very experienced spine surgeon. I know all the treatments available out there. I know if they work, they don't work. I know the risks, the complications that occur. And I'm very confident that this treatment you're watching is the very best treatment in the world, hands down, not even close to any other treatment for a disc problem. And that comes from performing all kinds of surgeries in my career over the years, from fusions to artificial discs, to laminectomies, discectomies, interspinous implants, everything. I've done it all. I've seen it all. I study it all. And I see what the best results are by far is the endoscopic Duke laser disc repair. That's why this is our procedure that we perform all the time here. It's not that we can't perform other surgeries. If you go back and look at my YouTube channel, we've been doing surgery here for 10 years. And in the beginning, it was mostly open surgery with fusions, laminectomies, discectomy, and I've done hundreds of them here in our center, and we've broadcasted them, almost all of them. And you can go back and watch those surgeries. You could see that I've done just about every surgery there is out there. But I don't do them anymore because they're completely unnecessary and they don't work as well. So my patients want the best for themselves. They want the fastest recovery. They want the fastest return to activity. They want the most successful surgery that can be done, getting rid of their pain. And that's why we do this procedure, because it works better than any other surgery to get rid of back pain. It works better than any other surgery to get rid of leg symptoms. Radiculopathy, basically. All right. Next question.
Our next question comes from Lydia, once more on Facebook. And they commented on your reply to them earlier. They said, thank you so much. And their question is, which location are you located, or will you travel to? She said travel to both, but I believe it's travel outside of the office.
Oh, hi, Lydia. Thank you for asking. So, Lydia, just to give you an idea, the center that we do this surgery at Duke Spine is a $10 million facility. And that means it literally costs $10 million just to build it and equip it. And actually, today is probably even more expensive. So we can't bring that $10 million facility everywhere we go. All the equipment, the staff, the supplies, everything we have here is personally handpicked, selected by me. And there is nowhere else in the world that has exactly what we have. We have the very best of everything. So why do we have the best? Because I picked it. I pay for it. I pick it. I'm the boss. But if you go somewhere else to another hospital or another center, they could have the wrong equipment, the wrong supplies. They won't have the right laser. They won't have the right fiber. And the people that work there aren't my staff. So they wouldn't know what they're doing. And what happens when you do that, when you start traveling around and doing surgery elsewhere, is that you increase the likelihood of having a complication. And the complication is something the patient has to live with. So I don't believe that's right to do, to move around and increase the bad outcomes or the chance of having a bad result. I like consistency. I'm a surgeon. Surgeons like to do things the best way every time. Okay, and that's what we do here. I can't do that if I travel around to other facilities, carrying my equipment bag with me. It would be a very big equipment bag, by the way.
I apologize. We have a comment from, or a question from Ada Sellers, and hi, she commented or asked, I am her daughter. She was wondering if it was at Melbourne or the Titusville location. We worded it wrong. Apologies.
Understood. So the Titusville location is just a satellite office. It's small. Our Melbourne location is our main facility. That's where the surgery center is. That's where the doctors and surgeons are. Melbourne. For those of you who don't know, Melbourne is located in the Space Coast of Florida. Of course, there's Melbourne, Australia, but we're not in Melbourne, Australia. We're in Melbourne, Florida. Of course, Melbourne, Australia is much more famous than Melbourne, Florida. Great questions. Just about done here with L4-5. And then we're going to go to the L5-S1. Remember, we're on the patient's left side. at this time?
Doing great.
Yeah, he's doing great. Dr. Berndes is really working hard, but doing a fantastic job. Dr. Berndes is the anesthesiologist, by the way. All right, what other questions do you have there, Henry?
No current questions, but we do have two comments. One from Estelle commenting, it's a great experience to hear from you. Nicely explained. Thank you so much again, doctor.
My pleasure, Estelle.
And
Where is Estelle located? Is Estelle in India?
That is a great question. We will find out in a moment. And, they just came up with a question, Estelle. The next comment is from Ada Sellers, and they commented, thank you so much. Sorry we worded it wrong, but thank you so much for your all's time.
Oh, it's my pleasure, Ms. Sellers. It's not an issue. I'm happy to answer the questions. But yes, obviously, you know, the surgery center is a very specialized center, and honestly, we have better equipment here than hospitals do for spine surgery. Obviously, we can't do heart surgery or brain surgery, but we do spine surgery, and we have literally better equipment than any of the hospitals in our county. And of course, we're what's called a focused factory or center of excellence, which means that we specialize in spine, and you know, because of that, we have the best of everything we need for spine. You're doing great, buddy. Hang in there. Almost done. All right. Next question.
Next question from Estelle on YouTube. They said, my last question of the day, do you use PTCD needle? Can you please show us the needle movement in respect to bevel? Specifically how to go deep and vice versa?
All right. Now let me thank you, Estelle. Let me have Henry repeat the question again.
Apologies. Estelle asked, my last question of the day is, do you use PTCD needle?
Is that what we use?
If so, can you please show us the needle movement in respect to bevel, specifically how to go deep and vice versa?
Understood. All right, well, I will show you the needle. The other stuff, in terms of placing the needle, I've already done. I can't do that again. But I could show you our needle. It is a beveled needle. We call it a, what is it called, Luis?
Spinal Chiva needle.
A Chiva needle? How do you spell Chiva? C-H...
Chiva.
Chiva, C-H-I-B-A? It's a spinal Chiva needle. C-H-I-B-A. You can type that up, Henry. All right, 30 seconds on this disc. On this side. We're done. Beautiful. Take that. Let me look. All right, watch the other stuff. Luis. All right, fine. I'll be happy to show you in a moment the needle. Henry will just do a eye in the sky view.
Copy that.
All right. I think we're done here.
Lights on, please.
Looks good to me.
Thank you.
The nerve root will be there to the side. You guys see the nerve root right there?
Yes, we do.
The white, the really, really pearly white. That's the bottom of the nerve root. That would be the L4 nerve root on the left. You can see how the herniation was right there pressing on it, irritating it. All right, so we're going to suck this out, and we're going to sanitize. Scope off. We're using a little betadine to sanitize the surgical field. We call it surgical irrigation. We've never had an infection in 16 years of doing the surgery. It's very safe. Wonderful surgery in terms of preventing complications. No infections. Hey, you're doing great, buddy. We're getting there. Almost done. Now I talk to the patients during the surgery, whether or not they actually understand what I'm saying or will remember what I'm saying is another thing. But, hey, you hold this? Yeah, he won't remember 95%, but I talk to him anyway just to comfort him, reassure him. And the truth is that the patients are fluctuating in their level of awareness throughout the surgery because we're giving them a medicine called propofol to sedate them and make them sleepy. But, you know, just like you when you sleep at home, sometimes you're a little more awake, sometimes you're a little deeper. And again, we can't just snow the patient, put him out completely cold, because then he'll stop breathing. And that would be really bad. You can imagine what happens then. We'd have to cancel the surgery. We'd have to try to resuscitate him. And anyway, beautiful. All right, so we're gonna do the last disc, which is the L5-S1 on the left. Then we're gonna get started on the right side. Once I do this left L5-S1, I think his back pain will be completely gone. I've got to do the right side just to make sure the nerves are decompressed. You saw how close the herniation is to the nerve root. It's right there, like literally millimeters away. You ready? Shot. Here we go. It's gonna suck. Shot. 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 All right, so I'm backing this needle out and I'm trying to make sure that I don't take out the guide wire at the same time. Shot. I think we're good. So I use a little technique there. All right, yep. All right, so you wanted to see the needles we use. Let me show you, Luis. This is the standard needle. Can you guys see this, Henry?
Yes, we can.
Yeah. This is called the Chiva needle. Keep quiet. You're doing great. See that? It's got a beveled tip, spinal needle. And then, of course, we have the Magnum for the big boys and girls. We don't discriminate, but you can see the difference. This is reusable. This is obviously not. So when we need that extra length. Okie dokie, artichoke. We're going to place our dilator. You're doing great, buddy. I'll give him some num-num. Some num-num, please. So I'm going to numb the patient's soft tissues up just a little bit, because it kind of hurts to go through the fascia. You know, there are certain pain-sensitive structures in the lower back, and one of them is shot. One of them is the fascia. So, shot. As I advance the dilator, you all can see that. Now I'm getting near the foramen, so I don't want to inject anymore because the nerve root is there. You don't want to put the nerve root to sleep, because then at the end of surgery you freak out when the patient can't move their leg. So it's always a bad thing after spine surgery. All right, shot. Great, so you can see the tip of the dilator is at the back of the L5-S1 disc, and now we're going to head into that disc so we can fix it. Now I'm going to aim a little bit medial, right? Yeah, you're fine, buddy. You're doing great. Now, I'm going to have to at some point remove this guide wire, because otherwise it's going to get pinched. Shot. That's my picture. All right, so I'm going to take the guide wire out because I can feel I'm up against the disc. I'm going to aim super medial. Lay still, you're doing great. I'm aiming medial with the tip. Shot. Whew. That's hard work. All right. So by aiming medially, I'm actually pulling lateral with my hand. I'm aiming the tip more medial. Because remember, that L5-S1 facet is trying to force me lateral with my tip. I don't want to go lateral in the disc. I want to go more medial. Can I have that, impactor? Any questions?
Yes, we have two comments and a question. The first comment is from Woody, and the comment is, I would also like to thank you guys for your replies.
Oh, you're welcome. You're welcome.
And no, I apologize. We have two questions and a comment. The first question is from Sharaf on Facebook, and they asked, my MRI was done in December of 2021. Can I send it to MRI review?
Yes, absolutely. I'm not ready yet. So the MRI review, the MRI was done in December of 2021. You're just a little bit over a year. Oh yeah, wait, let me see.
Let me put this.
No. Oh, okay.
Yeah. And make sure, yeah.
The answer is yes. You're just a little over a year, which should be fine. All right, we are going to the bottom disc, L5-S1, the hardest to treat.
All right, go ahead.
Universally the hardest to treat. And I'm going to just see where my tube is. Tube looks good, right? Shot? We're inside the disc. Well inside, yeah. Shot? Oh yeah, we're far. We're in. I could pull back actually. Pull back a little bit. Let me do that.
Yeah.
Whew. I mean, he is deep.
Yeah.
Shot? All right. I'll just get in there and pull back. All right, let's get the fluoro out. So we're just about finished with the left side. We've done 3 disc repairs on the left, L3-4, L4-5, L5-S1. We're about to start the third, the last on this left side. Then we're going to go to the right.
Yep.
So far, the patient has been, from a surgery standpoint, he's a 10 out of 10. Hardest you can do. From an anesthesia standpoint, 9.7 out of 10. Guys, I need the scope on. Come on. Yeah, thank you. All right, here we are inside the L5-S1 disc. I can already see the tear. You guys see the tear there?
Yes,
That's where the herniation came out. See the blue thing? That blue thing, it shouldn't be there. That is a herniation within the tear. We're going to bring the laser in and get started. Don't try this at home.
Just only one side. There's not too much.
You're watching the most state-of-the-art spine surgery in the world for degenerative discs. We don't use this to treat tumors or infections, which are very rare anyway. This is the most common problem people need surgery for is a bad disc. And this is the ultimate surgery for a bad disc. Now, could there be a better surgery in the future? Yeah, sure. But right now, this is it. And this is the best because, number one, it gets rid of the most symptoms of pain in the back and leg. And number two, it's the least invasive. Number three, it doesn't have complications. We've not had any surgical complications. But, of course, it could have a complication. It's not that it can't. It can. But it's the fact that there's no complications to date from the surgery is obviously, number one, it's a testament to my skill as a surgeon, and my team for doing an amazing job, right? Because a lot of complications aren't even the surgeon's fault. It's, the patient is not prepped properly for surgery. Maybe their heart hasn't been checked right or their labs. So it's really a team effort. It's not just the surgeon. A lot of complications of spine surgery come from the anesthesia, the anesthesiologist, okay? And, things like fluid overload or even dehydration and kidney failure from the surgery. There's a lot of complications that happen as a result of anesthesia from the surgery. So the fact that we've not had any of those complications is really an amazing feat for this type of surgery. Also, it's a testament of how less invasive the surgery itself really is. So, and then of course, another thing that's important to people besides getting rid of their symptoms and not having a complication is getting back to their normal routine. And because the surgery is done with a tiny cut and there's no painkillers needed after surgery, no narcotics, patients can go back to work the next day. Of course, they have restrictions. We're not going to have them lift heavy things. We're not going to have them bend over and pick things up from the ground like concrete bags or anything like that. But as long as you follow your restrictions, which are reasonable, you can go back to work in a day. And a lot of our patients do go back to work the next day. You can see their testimonials. They talk about going back to work. This patient here, because his job requires him to lift things, he's going to have to take some time off and go back to light duty. So after a period of time when the disc is healed enough, he can go back to normal duty. So basically with this surgery, once you're completely healed, which takes 9 months to a year to fully heal the disc, you can actually go back to pretty much any activity you want to do. Man, so I'm struggling right now because the angle that I had to get into the L5-S1 disc is pushing me against his shoulder, basically the bottom of his shoulder. And it's making it really hard to turn the scope to where I need it to be. So we're having to do a little jockeying of the scope itself. And the laser, of course. But that just is part of this being that level 10 surgery. Remember we talked about earlier.
We have a comment and a question.
Sure.
The comment comes from Food is Life and Love on YouTube.
I've seen a lot of comments.
And they commented, there are neurosurgeons and then there are innovators. Folks, you are watching an innovator.
Thank you. You're right. I appreciate it. And I'll tell you another thing. There are innovators that innovate for the wrong reason, and there are innovators that innovate for the right reason. And I believe if you're going to innovate in healthcare, you need to innovate for the patient to make their treatment better. And that's what we try to do at Duke Spine. There's a lot of innovation going on in spine, that things that are like metal implants being stuck in your spine, I don't believe those innovations are good ones. And I don't think that the surgeons that are innovating or the engineers that are innovating are doing it for the right reason. So I distinguish between good innovators and those that are motivated for the wrong reasons. But thank you for making that comment. It means a lot. All right, so we are in the herniation at L5-S1, and as I've said, it's extremely challenging because of his anatomy, is limiting us. And I'm having to wiggle my tube back a little bit just so I can get the rest of this herniation. See that right there? That is the herniation. It's stuck inside the tear. See how it jiggles around when I hit it with the laser? That is the interposed herniation, spelled INTERPOSED. And again, Duke Spine Institute's the only place in the world that actually treats this interposed herniation properly with a laser. All right, I need 5 minutes on this disc, doctor, and we'll be done here, and then we'll swing over to the other side. By the way, in case you didn't notice, I feel the hardest part of the surgery for me as a surgeon is the beginning, where we're placing those needles, because the needles have to be placed perfectly. If they're not placed perfectly, well, the rest of the surgery goes very badly for the patient and for the surgeon. So the success of this surgery is predicated on the proper placement of the spinal needle. And you saw in this patient, we actually started with a smaller needle that we normally use and had to change it up to a larger needle because the patient's girth was too big. His spine was too far forward. I couldn't access the disc properly. safely with the normal needle. So you got to be prepared to adapt your technique a little bit on each patient, depending on the circumstances that you encounter. I'm going to try to swing lateral. Damn. Again, a little bit blurry because of all the debris.
We have a question.
Yep.
This comes from Wizzy on YouTube.
Uh-huh. I think the scope needs to be repaired.
This scope?
Uh-huh.
And they asked, "Hi doctor, I'm grateful for all the orientations. What's the difference between bulging disc contacting nerve root and bulging disc compressing nerve root?"
There's really not much difference. Bulging discs are herniated discs. They're all the same. Protruded disc, bulging disc, extruded disc, prolapse disc, slip disc, they're all words that mean the same thing. As far as nerve root contact, what's important is it causing damage to the nerve? And that's determined by the physical exam. Is there weakness in the patient? Is there numbness on exam where that nerve is supposed to go? Are you finding dysfunction? We call that radiculopathy, dysfunction of the nerve root. So is there radiculopathy or not? And in the end, the treatment is going to be the same, whether there's significant pressure on the nerve root or not, whether there's radiculopathy or not. The problem is most surgeons won't operate on you unless you have radiculopathy. That's because that's how they were trained to do it. That's 50-year-old thinking. It's not modern thinking. But most surgeons are not trained the same. They have very big discrepancies in how they're trained. The reason for that is you're trained by your faculty. You're trained by your patients. So every surgeon's experience is different because their faculty are different. So if you have, mediocre professors, then you're going to have mediocrely trained surgeon. That's really what it comes down to. And I could tell you that the training centers always select the best doctors from medical schools they can. And that's how it was when I applied. The neurosurgery programs in the United States only took the top of the class neurosurgeons, and they all wanted the very best of the best. So there was a competition for the top doctors. And believe it or not, if there's 100 surgery training programs and there's a top doctor, he or she is going to go to the top training center. And they only take 2 doctors every year. So, and it's 7 years of training. So if there's 120 neurosurgery training programs in the United States, they're going to take roughly 200 residents in neurosurgery every year. And each one of them is going to want to pick the best doctor they can. And doctors are not equally trained either. So what they want is the ones who are the top of their class. So basically what I'm getting at is every spine surgeon is different because they're just different people and they're trained differently. So you get a combination of variability based on the individual and based on their training. For me, I wanted the very best training possible, so I studied hard and I made sure I was the top of my class. And that way I could pick the best training program rather than, not have that option. I wanted to pick the best for myself. So to do that, you have to put yourself at the top of your medical school class, which I did. And as a result, I got to pick where to go for my training. And I selected the very best neurosurgery training program in the United States, and hence the world. This was back in '97. So what I'm saying to you is every spine surgeon you go to is different, and they're going to recommend different treatments based on their experience and their training. They're going to recommend different treatments based on what they're comfortable doing or what they have equipment to do, right? Because even if a surgeon wants to do this surgery, if they don't have the equipment or the training to do it, they're not going to be able to do it. And they're going to have to do something lesser for their patient. Of course, they're never going to tell their patient, I'm doing a lesser surgery for you. They're all going to say the same thing, which is, oh, I'm going to do the best. Right? The best is a microdiscectomy or a laminectomy, but that's nonsense. It's not the best.
Thank you.
And unfortunately, the patients suffer as a result of that situation they're in, where their local spine surgeon or wherever they're going is limited in their ability to treat the patient. Let me have a grabber. 1 minute. 1 minute and we'll be done here. And then so I feel when it comes to spine surgery, what patients want and what they should strive for is the best possible outcome that a doctor can give them. And to get that, they need to have the best surgery done by the best surgeon. So, the time of, oh, all surgeons are equal, well, we know that's not true, okay? And all surgeries are not equal either. And at Duke Spine, we have the choice to do whatever surgery we want. And we always choose the best whenever we can. At least we give the patient that choice. We're done.
We're done?
Done.
All right. Lights on, please.
Well, that was really tough. So we're done with the left side, right? I wish we were done with the whole surgery, but we still have the right side to do. And I'm going to put some antiseptic again, as we always do. Now, what's nice is I'm going to show you in just a minute here. Let's turn the light on.
Lights on, please.
I'm going to show you in just a second here. I'm going to take this tube out, and I want you to appreciate the fact that all 3 discs were done with one little cut on his back. It's literally probably an 8mm cut, maybe a centimeter at most, centimeter, which is 10 millimeters. Millimeter is tiny, tiny distance. Why is the suction so sucky?
Can you check the suction? Yeah, it's not sucking that
The
much.
suction sucks.
Full or what?
I don't know that it's full. It might be. All right, so let me take this out. Look how deep it is, by the way. We're all the way to the hilt. You're okay. Look, let me have that.
Yes, sir.
Look at this, folks. Literally, that's how deep we were inside, all right, at an angle getting into the disc. Now, if this patient had a fusion, that's how big his incision would be. It would be massive. And it might even be bigger than that because he's so deep, I'd have to make it bigger just to get deeper. All the muscles would be peeled off the spine, the bones and ligaments removed, screws and rods. Why don't we show our audience the difference between Duke laser disc repair and spinal fusion? Because spinal fusion would have been the alternative treatment for him. Come on over, Oscar, hold this. Or have Luis do it. Pressure. All right, before we do that, any questions?
Yes, we have a question from Lori on YouTube.
Hi, Lori.
And they asked, how do neurosurgeons and orthopedic surgeons differ in the way that they do surgery? Is there a difference?
Yes. How do neurosurgeons and orthopedic surgeons differ in the way they do surgery? First of all, I know this may come as a shock to people, but just take the simplest surgery, a laminectomy. If you have 10 surgeons, all 10 surgeons, it doesn't matter if they're orthopedic or neuro, they're going to do it differently. They're going to do it differently. And when you get a picture of the spine after the surgery, you're going to see that every one of them did it differently, because no two are the same. That's the first thing you need to understand, is it doesn't matter whether you're an orthopedic surgeon or a neurosurgeon. Shot? I need to see further anterior. It doesn't matter if you're an orthopedic surgeon or a neurosurgeon. If you take 10 surgeons, you're going to get 10 completely different ways of doing the surgery. And you're going to have 10 completely different looking surgical fields, okay? Shot? All right, so as I remove the needle, shot, I want to check my guide wire and make sure it's not coming out. It's not, so I'm okay. Shot? All right, very good. We're at L4-5 now. So keep your eyes on L4-5. Jordan, show them L4-5. Right there. That's the L4-5 disc. Show them the tear in the back. Yep. So the guide wire is going right through the tear. That's where I positioned it. That way we're not doing any damage to the disc. Orthopedic surgeons and neurosurgeons, I can't give you a generalization, except that I could tell you a neurosurgeon is trained for 7 years in neurosurgery. During that time, 7 years, we are doing at least 50% of our work is spine surgery, spine patients, okay? In most good training programs. Now, it could be different in some programs, but at most neurosurgery training programs, 50% of the work is spine. The other 50 is brain or peripheral nerves. Now, orthopedic surgeons traditionally, in their training of 5 years, they don't do spine. They do knees, hips, shoulders, other things, but not spine. And the reason for that is at most universities where training occurs, the neurosurgeons have control of the spine. It's just what it is, okay? It's a monopoly, whatever you want to call it. Now, of course, there are some exceptions where, you know, some universities it's going to be like, well, orthopedic does spine here, but it's very rare. No. We're not injecting down at the disc. I'll just give them a minute. So I can't really make a generalization except that there are some really good orthopedic spine surgeons that I've seen. And there's a lot of bad ones. There's also a lot of bad neurosurgeons. So I'm one of those kind of people that feel if you're going to do surgery on something, you should make yourself really good at it or don't do it at all. And that's my philosophy. So I don't do a lot of brain surgery anymore, aneurysm surgery or pediatric tumors, because there's better surgeons than me, and I don't have time to go and learn all the latest techniques for brain surgery. Okay, I did all the brain surgery training in residency, but now that I'm out in practice, I'm doing mostly spine. Can you move that, Luis? Move this. And so basically what I'm saying to you is that unfortunately a lot of neurosurgeons don't do very good spine surgery, and a lot of orthopedic surgeons don't do very good spine surgery. So I don't discriminate, it's either one. But in my opinion, they shouldn't be doing spine surgery unless they're staying in the cutting edge and offering their patients the best treatment. That's just my philosophy. So when patients come to me with a metastatic brain tumor or a meningioma, I don't operate on them. I refer them to a better neurosurgeon than me, somebody who does that every day, because I believe that's what's right to do for the patients. If I was the patient, I want the best. Tell me one patient who doesn't want the best, right? So to get the best surgeon for your problem, unfortunately, they have to specialize, because there's, you know, it's the only way to stay up to date on everything is to specialize. And neurosurgeons that specialize in spine, in my opinion, the best ones are going to be the best doctors, better than orthopedic. Neurosurgeons are trained to deal with the spinal cord and nerves. Orthopedic surgeons are not. That's just a generalization. I don't like making generalizations, but you're asking me, So I'm just giving you my generalized opinion. There are exceptions always. By the way, we have, I think, a Ray Tech on the field here. Is that right? Yeah, a Ray Tech on the floor. Oh, yeah. All right, very good. So far, this patient is doing really well, and honestly, the surgery is going far better than I expected it to, based on his size and anatomy. Great questions from the audience. Any more?
No current questions.
All right, we're going to get started on the right L4-5, and then we'll go to the right L5-S1. We'll be done. So why don't you run the video comparing the DLDR to the alternative surgery, which would be a 3-level fusion.
Duke laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Duke laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Duke laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Duke laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Duke laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Duke laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Duke laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Duke laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Duke laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Duke laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Duke laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Duke laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Duke laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Duke laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Duke laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Duke laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Duke laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Duke laser disc repair, there is no damage to the muscles. The Duke laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Duke laser disc repair. Spinal fusions have a high risk for infection. The Duke laser disc repair has a very low risk for infection. In the 7 years the Duke laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Duke laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Duke laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Duke laser disc repair. In fact, most Duke laser disc repair patients experience improved mobility after the surgery. The Duke laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Duke Spine Institute. With the highest published success rate of 95%, the Duke laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
Welcome back. I'm Dr. Duke Majin. We're finishing up this very long and difficult surgery. It's a patient who has 3 disc herniations, L3-4, L4-5, L5-S1, and 2 of the discs, the herniations are on both sides of the spine, so they're affecting the nerves exiting behind those discs on both sides at L4-5, L5-S1. So we've had to do a bilateral 4-5, 5-1, and a left-sided 3-4 Duke laser disc repair. Now we've completed the left side and we've just completed the right L4-5. We're going to finish up with the last disc that needs treatment. It's the L5-S1 disc on the patient's right side. Shot? Now you can see in just a moment, shot, that we are at the L5-S1. We've done the entire surgery through 2 Band-Aid size cuts, one on the right, one on the left. Go ahead. Oh yeah, you can numb it up. Wait, look at your knee, look at your tip, aim down. Go ahead. We're going to give our patient just a little more numbing medicine to treat Dr. Berndes. Shot. All right. So, Here we go. Let's do a little more. Shot. Yeah. A little more num-num.
Okay, my friend, don't move your arm. Keep your arm
You're
still.
doing great.
Keep your arm still.
Our patient is under twilight anesthesia, which is propofol and MAC. MAC stands for monitored anesthetic care. He's getting oxygen, monitoring his vitals. Shot. Propofol is the best drug we can use for this kind of surgery. We also give a little fentanyl for pain and a little Versed to calm the patient and help them not remember the surgery. Yeah. For those of you wondering, almost done. You're doing great. Hold on. I'm going to pull the guide wire back just a little bit. Shot. All right, beautiful. And I'm going to, having to aim medial and inferiorly. All right, shot. Great. Let's get the, hold on, take this. Let's get the guide wire out. And I'm ready. Bingo. We are just about finished with this very long surgery on a very difficult patient who's traveled to Florida from Louisiana for severe back pain. As a matter of fact, such severe pain he's had for the last few months, he couldn't even get out of his wheelchair. When I did my telemedicine interview on Zoom with him, he was in bed. And what is it? I said it didn't take much for him to get me in bed with him. Shot. You're okay. Shot. All right. Hold on. I think, yeah, you can pull it back a little bit. We're just about there. I think we're there. What do you think, Luis? Is it coming? You want to put the cap on? Think the cap needs to go in a little further? Hold on, let me see. Shot. All right, put it on. So we're just trying to get the dilator out for the last disc. A little teamwork makes the dream work. Take that off. Let me see. Go ahead. Shot. Of course, have to have shot. Issues on the last one. Move. Off. Off. Come off with that. What we've got is a little cold welding between the dilator and the outer tube. Right, it's moving, right?
Yeah, it's moving up. Yeah.
Whew. Is it still moving?
Yeah, yeah, it's going up.
All right, hold on. Let me get the wet. I need a wet ray. Hold on, I get it, I get it. a little problem solving, friendly operating room problem solving going on. Shot. Oh, let's pull the whole thing back. No. I've got to release the dilator from the outer tube. What's happening is a little bit of the disc material is getting caught in there. Huh?
I think that the tubular is kind of out. You want to push it more?
Let me have the, what, push what more?
The tubular.
You mean the tube?
Yeah.
Yeah, the tube is out. I know that. But I'm trying to free the space between this dilator and the tube.
Two cokers, one on the bottom, one on
Mm-hmm. What a pain in the ass. All right, we're going to do one more attempt, and then I'm going to just have to use the guide wire, and we're going to have to take it out.
Nope.
Uh-huh. Shot? All right, so shot. You're fine. Shot. Yeah. Put that back over here. I don't want that floating around. You don't have the skin, right? You're not grabbing the skin, right? Just to make sure. Nope, you're taking the two. Well, are you? Shot? I think we're good. Keep going. Nice job, Luis. Yeah, Luis here to save the day. Good job.
I had some input too.
Yes, Dr. Berndes. We had already tried the coker. That was it. That was our second time trying the coker. All right. Lay still. You're doing great. We're almost done.
How are you feeling?
I'll see.
All right? Tired?
You're tired.
Tired.
What do you mean you're tired?
Tired.
How about the rest of us who are actually working on your back?
Tired.
Ugh, I got it. It's slippery. How is it not grabbing? There we go. Alrighty. Let's get the scope on. Last one. That's funny. He's tired. We're tired. He's going to get a good laugh at this when he goes to watch it. All right. L5-S1, right side. Last one. You can see we've taken the tube right to the hilt. It's literally as deep as it can go. So he's maxing out our instruments. A lot of patients who are really obese have back problems. Doctors just don't want to operate on them because they're hard. They take a lot of effort and they get complications often from surgery because of their size and comorbidities. So a lot of doctors just aren't interested. A lot of surgeons don't want to help people that are overweight. They discriminate against them. We don't. At Duke Spine, we try to help everybody. We don't care what your weight is, age. We don't discriminate in any way. The only time we ever don't do surgery is if we can't do surgery. It's just impossible. Either physically the patient doesn't have the right anatomy, which is rare, but it does happen. I think the tube is backwards. Just thinking, yeah. So, scope off, laser off.
Lights on, please. Thank you.
Nope, nope, I gotta flip the tube. That's all. The tube has an aperture and it's pointing in the opposite direction of where I want it. All right. That's better. All right, we got 8 minutes, 10 minutes max. We'll be done. Any questions from our audience?
No current questions, but we do have a comment from Woody on YouTube. And they said, "It's fascinating to watch. I was convinced a new disc was my chosen path until I found this channel. Thank you."
Oh yeah, you're welcome, Woody. No, you don't need a new disc. I don't recommend it. There's lots of problems with artificial discs. Patients have problems afterwards, and the surgery itself is extremely risky. They got to go through your belly, which, you know, that's the riskiest of all spine surgery, is going through the belly, the abdomen. And it has the highest complication rate. This is natural. There's no metal needed. If an artificial disc was a better surgery, we'd be doing it, trust me. I started doing artificial discs back in 2001, I think. 2000 maybe, 2001, with my professors at Shands in Gainesville. And we were part of the FDA studies for safety. And the things that I saw with those patients that had artificial discs, the complications, and more importantly, the fact that the companies that sponsored the artificial discs, paid for them and manufactured them, they would hide the complications from the reviewers. It was so corrupt. And the reason they hid the complications is they had invested millions of dollars into that technology, so they wanted it to be approved, they wanted it to be accepted and used. So when you have bad results, they started hiding the bad results. And the way they hid it was they would get rid of those patients out of the study. They would come up with some reason to eliminate them out of the study so they weren't counted. It made the artificial disc results better than they really were. So I saw that happening over and over again, and I just felt it was so unethical and corrupt. So compared to the fusions, artificial disc results are a lot worse, in my opinion, from my experience of seeing it. But you wouldn't know that because they hide that in the data. They cover it up. I try to tell people this in my YouTube channel. I go through explaining just how bad artificial discs are. So I appreciate the fact that you're learning something. All right, grabber. Just about done. You can see the pink thing on the right is the bottom of the vertebral body. We call it the end plate of L5. And then you can see this is a piece of herniation coming out that I grabbed. Yeah, he is happy. Almost done. He can feel those herniations coming out. And
Almost done.
what's hurting? Uh-huh. Get the 12 lead EKG ready in recovery just to make sure. Okay. It's probably muscular, but I don't want to take any chances. Just about done, my friend. Well, we're working on the last part. Got about 2 minutes left. Do I have 2 minutes?
Yep.
Just want to try to get all this stuff out. All this junk. Well, with that complaint, I don't know how concerned you are. Are you concerned? All right. Well, I agree. Don't like to assume anything. 1 minute left, I think. Unless, yeah. Yeah. You're doing great. Oh yeah, I know. Maybe he has a little costochondritis. Yeah, this is the... Luis, I need a little more laser to the middle. Yeah, I think so. 1 minute. Everything okay? Huh? All right. Grab her. Are you monitoring end tidal? Well, he's definitely not asleep enough not to breathe. That's probably the best I can do given the circumstances. Looks good. I think he's going to be happy with that. One more grab and I think we're done. I'm going to grab lateral. That's just that's your last disc we're fixing. 30 seconds. You're doing great. All right.
Lights on, please. Thank you.
Scope off. Well, folks, we did it. Certainly one of the hardest I've ever done. Seem to be getting a lot of them. But the good news is the pain that he's had since his accident is now going to be gone, I believe, in his back and legs. I expect to see a new man tomorrow. No more wheelchair. Just cleaning out the antiseptic. Huh? Yeah, we're just finishing up. You're doing great. Relax. We're almost done. All right. Done. No, go ahead. So, Luis, can you see this here, Henry?
Yes, we can.
That's the incision, folks. 7 millimeters. All right, we're all done in here. Henry, why don't you run one of our testimonials, and I'll be over there to answer questions in about 5 minutes.
Copy that.
You're doing great, buddy. We're all done.
Yeah, I mean, this gives you hope. I can't even explain it. If you're watching this, please, please, please call Dr. Duke. Send in your stuff. You can upload it. You can mail it in. You can have a Zoom conference with him. Took 10 minutes. And he offers something that no one else does. Yeah, you'll have to travel to Florida. Well, that's real bad, Florida. Well, where I come from, that's a vacation.
And while you're here, you can visit Mickey Mouse.
Yeah, right. I'm telling you, do it.
Good morning, I'm Dr. Duke-Magin. It's September 16th, and we're here with another one of our post-op patients who had surgery done yesterday. Now, he came to us from Pennsylvania, and he has been suffering with back pain for many years. He had a fusion done up in by Dr. Alex Vaccaro, multi-level fusion done, and he developed adjacent segment disease from the fusion. So the disc above and the disc above, so those two, L2-3, L3-4. He was having horrible back pain there yesterday before his surgery. How are you doing today?
I'm doing excellent. I can't even tell you how good I am. It's just like night and day. You come in one day, you're in total pain, had it for years. You go through this procedure that he has, and it's really amazing. You go out of there literally feeling better, and then I'm sure it's going to get even better and better and better. But I'm literally, that pain is gone. I just can't even explain how much different it is.
Yeah. And you were feeling pretty down and hopeless when you came to us at Duke's Spine. How do you feel today?
Oh, way better. When you have chronic pain, especially for years, like you start off going, okay, I can go get this fixed. I can go get this fixed. Well, after years of going through this and then that, you run out of options. You're pretty much hopeless. You don't even want to live, really. You just want to, I don't know, you just don't want to live like how you're living. You want to live, but you don't want to live that way. And now I feel like I can get back to doing some things that I like. It's just,
well, not too soon, because you just had surgery. So
Yeah,
we're going to take it easy for a little while. Now you can see in the surgery here, we went in to your L2-3 and L3-4 discs, and we used the laser to remove the herniations and clean up the annular tear. And it's the annular tear in the back of those discs that's the actual cause of your pain. And that's what we were able to treat with the laser endoscopically. So there's only a 1/4 inch incision, which I'm sure you've seen on your back.
This incision is this big. It's unheard of, really. If I was to get another fusion, which was my option, that or a stimulator, were both more invasive than the stimulator more invasive just with that, but then also with the fusion, I would be in bed yet. I would be in bed for another couple of days on a traditional fusion, laying there for 2 to 3 days, wearing a solid body cast for 3 months, and then I can actually start therapy and maybe go back to work at that point.
And you're speaking from experience, because you have the fusion
I've done
already.
I've done all this, and they were my options. They wanted to either fuse or do a stimulator, because I already had a pain pump in that was in, and I was having problems with that. So they were my 2 options. So I literally dug high and low, looked on the internet for everything, found Dr. Duke, and right away I sent him my MRI. He noticed it right away what it was. He didn't go, oh, it's this or that, or try to guide me in any way. He said, this is what your problem is. This is what I can do. We can help you. Scheduled, came down, boom, boom, boom. Now flying home today, totally different person.
Yeah, yesterday his father said to me right after surgery, when he saw his son walking and standing without pain, he said, you saved my son's life. And what did he mean by that?
Well, anyone out there watching, if you're watching this, you probably had chronic pain and you're looking. And your family gets pretty much the blunt of everything, because you'll go to work and you can't cry at work and you can't complain, and you got to do your job and you got to be pleasant. So you put on an act all day long, but when you get home, your family gets it. Your family, your close friends, and you just release to them. You cry to them. They don't know what to do. I've heard many times from him, Brian, I don't know what to tell you. I can't help you.
They don't know what to do, because the doctors don't know what to do either.
And you're just kind of venting to them. You don't really want them to do anything. You just want them to listen. And it's hard, because you should be taking care of your parents and your kids. And here you are feeling helpless, and they don't get it because they don't have the pain. They just, and then people just think you're complaining, or you don't look bad. I seen you smile. Oh, I seen you laugh. But
they don't understand.
You go home by yourself, and it's like, what am I doing? I go, what kind of life is this? I just want to go to heaven and not have pain. And it sounds horrible. You don't want to. You just don't want to live that way, because you're not living.
And do you feel that way now?
No. This gives you hope. I can't even explain it. I can't even explain it. If you're watching this, please, please, please call Dr. Duke. Send in your stuff. You can upload it. You can mail it in. You can have a Zoom conference with him, and he will know right away. Right over the computer, I did it with him. Right over the computer. Took 10 minutes. And he told me right away and by the time you're doing this, you'll kind of know what's out there. You've been through everything.
Yeah.
And he offers something that no one else does in the whole world. And you'll have to travel to Florida. Well, that's real bad, Florida. Well, where I come from, that's a vacation.
And while you're here, you can visit Mickey Mouse.
Yeah, right. I'm telling you, do it.
All right. Anything else you want to say to your fans out there?
Yeah.
And your father?
I just want to say my mom and dad are great through all this. My kids, I have a granddaughter. I can't wait to go home, and I won't pick her up because she's over 25 pounds. But that was literally, my granddaughter was the one thing keeping me going. When my granddaughter was born a year ago, that gave me new incentive. I wanted to be around her, chase after her. And now I can probably do that.
Yes, you can.
And I can't tell you enough. Just call them. Like, don't waste your time even doing some of this other stuff. I did it all. You will be right back to square one. And if you call him, you can still do whatever you're going to do later. You can. Say you want to go get a fusion, you're stuck on that. Come talk to him first. There's certain instances where, yes, a fusion is necessary, but he does those also, a different way too. But there's no harm in contacting him, getting a free opinion. Then you can decide later on. He's not changing your anatomy. Your anatomy is the same. Once you get fused, you're like that. You're stuck.
Yeah, you're right.
But just call him up, and trust me, you'll be happy.
Thank you very much, and congratulations.
Thanks
This
a
is
lot.
why I do what I do. See that smile?
Dude.
That's a real smile.
Thank you. I'm telling you, he saved my life.
You're welcome, sir.
Thank you.
You're welcome. This is Dr. Ara Duke-Majan, CEO and founder of the Duke Spine Institute. I'm here with one of my patients, and you've traveled from where to the Duke Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Duke laser disc repair done and the Duke plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
well, it wasn't there yesterday.
Yeah, it wasn't there before surgery. And how long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
Well, the really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep Jeff's hopes up. I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well.
Yes.
And so what are you going to do now that you've had the surgery? And you could see actually the Duke laser disc repair procedure she had done yesterday. You can see right here, we went into the discs that were damaged. You had 2 annular tears. We tested your discs during the surgery, and indeed they were causing your pain. So we verified that with our discogram. And then I went ahead and used the laser to clean up the tears that were causing your pain and get rid of that source of pain for you. And here you are, you're doing fantastic. How much of your back pain from before surgery do you still have?
Oh, virtually nothing.
It's gone.
It's gone.
Cured.
My lower back, I have not been without pain in my lower back until your surgery. It's constant, it's always there. I've never been without it. I'm without it now.
So are you going to go back to gardening?
You bet I am.
All right, very good. And what other things would you like to do now that you have a new back that doesn't hurt you anymore?
You know, the biggest thing I want to do? I want to go fly a kite.
Good for you. Let's go fly a kite then.
That's right.
Well, congratulations on having faith
Oh,
and being
thank
brave
you.
and getting it done.
No, not a problem.
Is there anything else you want to say to your fans out there?
I highly recommend Dr. Duke's Spine Institute, Dr. Duke personally, to help you fix your back.
Thank you. Appreciate that. All right. Safe travels.
Phew, that wasn't too bad, was it?
It was wonderful. Welcome to our broadcast. I'm Dr. Duke Majan, and I was just in the operating room with you. We were performing surgery on a patient who's traveled here from Mississippi, right? Sorry, maybe it's Louisiana. I'm so sorry. Louisiana. And he has injured his back. He had 3 herniated discs, which if you were watching the live stream, you could see in the bottom corner the MRI that showed 3 dark discs in the lower back. And it turned out on examination his pain was right there where those 3 discs were. Also, he had pain going from the back down his legs. And that's because the nerves were getting pinched in the neuroforamen right here as they were coming out of that foramen going down the leg. And they were getting pinched on the right and left side. So we went in on both sides at L4-5, L5-S1, where there was herniations on both sides. And you could see the herniations were pinching the nerves on the MRI. And then at L3-4, we went in on the left side only because we didn't need to do the right side. So the approach we take basically is where this paper clip is. You can see it there. It's called transforaminal because this is the foramen, this space right here, and we're going across the foramen into the herniation. And this is basically my needle. Now, this patient had big facet joints. So big facet joints means they were moving out to the side, which made access to the disc harder to achieve. Okay, imagine trying to get into the disc there, okay? So I had to come further from the side to get there. And of course, the L5-S1 disc, which is almost impossible to reach anyway, was even more impossible in this guy. But we were able to get all the areas treated perfectly, and you could see the tears in the back of the disc in the annulus with the herniated disc stuck in the tear, and that's where the back pain was coming from. And I was able to clean it all out. One thing one of our viewers noticed and commented on earlier was, what do you do about a central disc herniation? Well, it turns out that central disc herniations don't really cause that much back pain. The back pain really comes from sort of the back side of the disc, the posterolateral area of the back of the disc, rather than dead center. So I never actually get all the way to the center with my laser. I always leave the center area alone, but the patient's pain goes away completely. So clearly that center area is not as important as the posterolateral regions of the disc. This is the back sides of the disc, kind of where the nerve root is. All right, and there may be a reason for that because the innervation of the back of the disc comes from a nerve called the sinovertebral nerve, which is a branch that comes off the dorsal root ganglion and right near the dorsal root ganglion, the sensory nerve root. And it sort of enters the disc in the back of the disc right where kind of the back side, right where the tears and herniations are. And that's why I think there's so much back pain, because that sinovertebral nerve carries somatic afferents up to the primary somatosensory cortex, at least to the thalamus, which is a way station of sensory input to the cortex, and specifically what we call the VPM and VPL nuclei, which is the ventral-posteromedial, ventral-posterolateral nucleus of the thalamus. And so those pain fibers in the disc travel up through the nerve roots into the spinal cord, and then they travel through a tract, which is a group of nerves that travel up to the thalamus, which is located just above your brainstem, and then they synapse there, and then the thalamus gates those impulses and decides which ones ascend up to the cortex brain up here, which is where all your consciousness is, okay? And so those impulses that you're feeling back pain, like this patient did, or anybody with back pain from a herniated disc, those impulses pass through the thalamus and hop onto the next nerve and make their way up to the primary somatosensory cortex. Anyway, we're attacking pain at its source, which is the annular tear and the inflammation in the annular tear. And that's why we do the Duke laser disc repair. It's the only surgery in the world that targets the source of back pain in the disc or the source of back pain at the facet joint. All right, we'll take our first question.
That is it. No current
We
questions.
answered all the questions already. Wonderful.
Yeah.
We'll be back in 30 minutes for another Duke laser disc repair. The next patient is a lady who's got back pain at L3-4, L4-5, L5-S1, and the herniations are causing back pain, plus they're affecting her nerve roots going down her left leg. So we're going to be going on the left side to decompress the nerve roots and debride the annular tear to get rid of her back and leg pain. So join us in 30 minutes.